Welcome back, everyone. We are excited to hear Dr. Schrieber going to talk about the roadmap to 80% Advanced American Kidney Health Home Goal Initiative, the reality check. I guess I don't need to introduce Dr. Schrieber. Everybody here knows him. He's the CMO of the VITA Home Modality Program. And also previously he was the chair of Cleveland Clinic Nephrology Department. Note, first time I met Dr. Schrieber was back in 2006 when I was attending as a fellow, attending the PD Academy sponsored by University of Alabama, Birmingham. And that's the first time I met Dr. Schrieber. This very nice guy at the front talked about two things I remember clearly. One is value-based care. It was a new concept to me back 15 years ago. The second one is a life planning for a young person who has kidney problems. That's what he said, quote, "You need to plan ahead for the whole life for that person. You cannot just put a catheter and start that person on hemodialysis. You need to have all the tools you have, start on PD. Hopefully he can get a transplant. And if the transplant fails, you may be back on PD, try to avoid hemo as much as possible." Here he is, after 15 years passed by. I still remember that. And he's been a leader in home modality. Thank you very much, Dr. Schrieber.
Thanks, CJ. It's really a pleasure to be here, and I want to thank the organizers for inviting me to participate in this very important conference and to really have an opportunity to share with you some of my thoughts about the Advancing American Kidney Health Initiative. These are my disclosures. I'm currently the Chief Medical Officer for Home Modalities at DaVita, and I'm responsible for quality for both the adults and pediatric population. And we dialyze more children with end-stage disease in the US than any other provider. There are three specific components of this talk today that I really want to share with all of you. The first is that I want to really examine the ecosystem, or what is the impact of the Advancing American Kidney Health Initiative? And then the second is, faced with that, what are the action steps that we're going to need to take going forward? And I'll review what I think are critically important action steps for all of us to consider. And then how do we measure our success going forward? So I'm super excited to have the opportunity to share some of my thoughts, and here we go. So in October of 1972, President Nixon signed an order expanding the Medicare coverage to include end-stage kidney disease. And it really wasn't until the recent executive order that kidney disease became front and center once again. And what's fascinating is there are three specific aspects of this that I think are worth emphasizing. The first is that there is an important initiative to reduce the number of Americans developing end-stage kidney disease by 25% by 2030. We haven't heard that focus on chronic kidney disease since Medicare started coverage back in '72. And the second point is really having 80% of the new ESRD patients in 2025 either receiving dialysis at home or getting a kidney transplant. And we really want to double the number of kidneys available for transplant by 2030. And what's important to remember is these are aspirational goals, and it's very important that we really think about how should we be approaching these initiatives at this time. And so with every challenge or aspiration, there's a solution. And I'd like to really quote Lisa Koister, who really gave a great presentation at ANA this year in April. And she also was awarded the Barbara Prowant Award for nursing recognition at ADC last year. And she truly is a nurse practitioner champion. But it's worthwhile to reflect on some of the comments that she made. And the first is that at the current rate of growth, we can expect to achieve a 50% home dialysis rate in about 50 years. And I think that if we continue to do things the way we do them today, we will not achieve this aspirational goal. And so we have to change. And, you know, as she paraphrased, we've been waiting for this for a long time. We've been waiting for recognition of the importance of home for a long time. And now it's really up to us, not the system, not the government, but it's really us to really change. And it's important to think about this because, you know, when I said in the title, this is a reality check. A reality check is defined here as an occasion on which one is reminded of the state of things in the real world. And so where are we today? Because that helps us understand what we need to do to get to where we want to be tomorrow and to meet the aspirational goals. This is an awesome opportunity that we have in front of us, but we again are the ones that have to change. And if we think about it, where are we today? Well, patient education targets for new end-stage kidney disease patients, instead of being at 80%, are down 20-30%. And only about 12% of end-stage kidney disease patients in the United States currently manage their disease at home. And when I think about all the patients that start their dialysis journey in an in-center program, there are a low percentage of patients that actually convert to a home modality once they start in an in-center program. And there are a significant percent of zero conversions, home programs that have no conversions. Patients start in-center and they stay in-center. And the other aspect of how we're organized across the United States is that there are a significant percent of home programs that are ultra small. And within DaVita, we have about 40% of our programs which are less than 11 patients. And that's important because we know that size matters, since size is one of the determinants or factors that determine program patient outcomes. And so we see across the United States significant variability in outcomes. The other hurdle that I'm going to touch on really is with respect to the nursing shortage. And the decrease in new nurses and drop in nurse retention is something that, unless we address it, it's going to have an adverse impact on home growth. And then the other aspect of this is that most nephrologists really aren't trained in home dialysis, home modalities. This is especially true with HHD. And there are few nephrologists which are subject matter experts. So this is the reality check, but I believe we can actually conquer these and move forward. So let's take a step back and think about what is the impact of the Advanced American Kidney Health Initiative. And I've developed this scheme just to represent the ecosystem of the bill's impact. And so it impacts CKD patients, primary care, non-nephrology specialists. It impacts nephrology practices. It makes us focus in on patient ed. Hospitals need to change to accommodate the increased growth and develop an expertise in placing peritoneal catheters and in caring for patients on peritoneal dialysis. We're going to need changes from a policymaker standpoint, because as we grow, we're going to need some incentivization, which is going to really necessitate a change in policy. Dialysis organizations have to focus on home growth. Dialysis manufacturers have to respond with adequate production of supplies that are needed. Technology, I believe, needs to really move us from where we're at today to in the future. And that relates both to the development of the digital technology as well as changes in the devices themselves. And we need to go upstream. We need to connect with primary care and with the non-nephrology specialists like cardiologists, endocrinologists. They need to be part of timely referral to nephrology practices and recognize the importance of, educating patients. It was back several years ago where I realized that there were changes that we really needed to make, and it was highlighted in the Harvard Business Review of all places. And there are some implications of nephrology practices that do not change, and I'm just going to cover a couple of them. So we learned from Kaplan and Haas, who are well-respected economists in the United States, that there is a significant negative impact if patients start dialysis as crashers and they use a CVC to initiate their dialysis journey. And they really focused in on the significant increase in cost that results from crash starts, and question, why can't the system provide education, modality selection, establish an access before patients need it? And what I'm seeing now, some early signs of what I would call limited network design, where if you as a practice are costing an insurance carrier more, or a health plan more, or Medicare more, you may not be part of the design network for delivering care. So this is serious implications on your overall practice, because if you're not part of a network due to cost, then you'll lose that group of patients to another practice. And so as we think about practice inclusion going forward, every nephrologist needs to sit and understand their data and how they're doing. And so there are three lenses that I would encourage all of you really to consider. One lens has to do with total cost of care for end-stage kidney disease health episodes. The other is quality, understanding your quality. Do you really understand your quality and the quality you're delivering? And then the last really dimension to this segmentation is going to deal with patient experience. How do your patients view your practice is doing? Being successful in the new world is going to require us reimagining what we're currently set up to provide today, but also to look at where do we need to go? What changes do we need to make in order to survive in this new world? And I have to give a lot of credit to Leo Pravovro, who really, in my mind, wrote one of the impact papers back in 2019 about this concept of integrated care delivery. And this was from Kaiser Permanente in Northern California. And the great thing that Leo did in my mind was he not only wrote the paper, but he gave, complementary instructions to what people needed to do as an accompaniment to the paper. And so his group, and he went above and beyond for an author in my mind and wrote this great paper. And so I would encourage that every nephrology practice should read this paper and think about, how do I develop this integrated model for my practice, for my health system, for my community, for the region? And how do we make this work? Because if we do, we can significantly increase the numbers of patients that are optimally started, that are not crashers. We can significantly increase the numbers of patients that are both comfortable and confident that home is the place where they want to manage their disease. It's going to depend upon a comprehensive program, including upstream primary care, upstream non-nephrology consultants. It's going to really necessitate collaboration with your hospitals and the community, meeting proactively with them, and ensuring they're ready to accommodate both the care that's required of patients if they develop a problem, or the actual initiation of dialysis and the placement of both vascular access and peritoneal dialysis catheters. And, you know, the other important point is the patient needs to be at the center, in really being a participant in their care, and really have what I've always championed, life care planning. So let's take a look at some of the actions that are required. And I've listed 13 here, and most recently, the chief medical officers for the dialysis providers have gotten together and really focused on how do we think about this clinically. And as we do this, more and more opportunities come up as to how different people are seeing things that we need really to add to this. And so we've expanded beyond the 13 here, but I think it's important to really call out what are some practical action steps that all of us need to really initiate. And it really comes down to, we have to get upstream. We have to educate the primary care practices. We have to really ensure that every nephrology practice in the United States has educational opportunities for patients, that it becomes a practice culture, that we set goals and targets for home dialysis, that we are able to place accesses in a timely way and think about the use of an embedded peritoneal catheter, because you can't actually time every single patient when they're going to need to start dialysis. And this is a critical step. Patients that crash into the unit, we need to educate them. We need to, you know, give them the knowledge where they feel confident that they can really do the therapy at home. We need to think about not only what the home of the future is, but what does the in-center unit look like in the future, whereby we use transitional care units and other approaches to really advancing knowledge in patients. We need to think about how are we more creative with patient training. I've really been big recently about learning styles and matching how we train patients with learning styles. And some patients may have a learning style which necessitates longer training, more demonstration, more tools, more hands-on. And we do that to avoid complication. Developing training whereby we can use virtual training, virtual technology to train patients. Can we train them in the home? I believe we can do some retraining in the home. Physician education is absolutely key. Nurse education, recruitment, and retention is a focus area we all need. I'll say a couple words about patient losses. More and more, we're seeing hemo machines, peritoneal machines, which are connected. You know, home remote monitoring is quite helpful as we move forward. And then care management, virtual remote management, leveraging the identification of patients that are high risk or rising risk is important. And so all of these action steps in some way is going to touch our practices as we go forward. And as we think of the home of the future or the in-center unit of the future, you know, it's going to be about technology. This isn't like the Jetsons. This is here now. It's not in the future. I mean, our ability to connect with patients, the Alexas of the world are going to be more incorporated into dialing into the dialysis unit, posing a question, interacting with peers, with support groups, monitoring patients, capturing the data in the home, and managing that data such that you extend the home program into the patient's home is critically important going forward. It can't be done alone. We need to reimagine what is the in-center unit of the future and really shape that going forward, whether it be a transitional care pod in an in-center program, whether it be in the home training area, patients that are starting to develop transitional issues in peritoneal that they may need to transition off the therapy. We ought to be incorporating them into a home hemo atmosphere with the teammates that they already know. And so having an experience of difference, like Next Stage likes to refer to it, in the home program for PD patients to begin thinking about their next step in the journey, I think is critically important going forward. We need to grow, definitely, but I have to tell you that growth alone, or new patients alone, whether they be new patients, incident, prevalent, or failed transplants, aren't enough. We have to really focus in on decreasing our losses. And as I said to you before, across the United States, there's significant variability in the percent losses that are critically important. We need to know, why are patients being subjected to modality loss? Why is that happening? What are the reasons? What can we do about it? And we really have to focus in on decreasing our losses. You know, I mentioned that I am quite concerned about the nursing shortage in the United States and the need really to transform nursing. And technology can do that. And we need to shift from an old model of nursing really to a new model of nursing, which leverages technology to make home therapies an attractive starting point for nurses. I say that because in nephrology in general, you really practice broad skills, you develop broad skills in medical care. And imagine if you could couple advancing your knowledge base with virtual attributes that you can use in other areas. It would really open up a door for more nurses to really start their careers or to join units or programs in home dialysis. You know, it's about virtual options. How do we train patients? How do we follow patients? Delivering care anywhere. Focus on how do we think about, you know, decreasing losses, optimizing care. What an arena to learn, in my mind, going forward. It's absolutely spectacular, and we all need to be excited about it. And when we think about virtual care, as I have on this slide, you know, DaVita has developed a HIPAA-sensitive program called DaVita Care Connect, and it's just not about getting information into a platform. It's about doing virtual visits. It's about moving educational information to patients. It's about patients being able to see their labs on the app. It's about scheduling. It's about uploading information. It's about doing a visual inspection of the access site or the catheter exit site. So it's really a new mode of conducting a home visit. And we have to get better at it. And the more we do, the better we're going to get utilizing this approach. You know, everybody talks about the downside of COVID, and admittingly, it has had a devastating impact on the American public. And it's caused significant stress within the healthcare workers and all of you. And I know you're all on the front lines contending with this. What I have appreciated from COVID is the ability to keep people safe in their homes, safe distance. Not to have to go out in the community, travel to a dialysis unit. And in those areas that have significantly high rates of viral contraction, doing a visit at home is really a way to avoid that, to keep people safe. And we've seen at DaVita a 70-fold increase in the installation of this application I talked about in the prior slide. We've seen a 53-fold increase in telehealth appointments. And if we look at all the visits that we've conducted by telehealth, it's a 106-fold increase. Physician visits have increased by 35-fold. So physicians that were not comfortable doing this beforehand, they've put patient safety against their own concerns and have really rallied around, my first goal is to protect the patient and protect the teammate, protect the nurse, the PCT. And I'm really going to learn how to do virtual visits. We have to keep learning as we go forward. And so as we think about it, there are a number of points for measuring success as we address the executive order. And one is, determine the percent of patients educated prior to dialysis start in your practice. You can do that. We need to really move that up. And then I said it's got to go from 20 to 80. There's no reason we can't educate patients. We'd want to be educated if, in fact, we were faced with needing dialysis. We need to track the patients that are starting with the CDC versus the number of patients that are starting across the board on end-stage kidney disease. CDCs present a significant threat to a patient from the morbidity standpoint as well as a mortality standpoint. And they're preventable if we would educate and track patients. This may be not just a practice issue, it may be a community issue, but it's something we definitely need to really move forward. We have to track our quality. Every program should know their quality metrics. And I have 4 what I view are key predictive indicators for how a patient's going to do. And it's hospitalization rate, it's infection rate, it's adequacy, and it's patient loss. Knowing those will help rank your program and for you to know how you're doing. Wouldn't you want to tell your patients you're in the top 80% as opposed to we're down in the bottom 10%? Patients need to know what your quality is, because going forward, that's how they're going to judge whether they want to be in your practice or not. And you really need, in my mind, to regularly examine percent of patients undergoing virtual visits versus face-to-face and the impact on quality metrics. We're learning now how to do virtual visits. We need to be sure that doing virtual visits is not going to negatively impact peritonitis rates. It's not going to negatively impact adequacy. But we have to get better at doing virtual visits. I don't think everybody is doing the same type of virtual visit or has the same success going forward. And so as I summarize this topic today, and I know I've talked about a number of different exciting areas, and this truly is a transformative point in kidney disease in my mind, in the ability for us to think more about home. Home ought to be the default modality and not a modality that's thought of if a patient doesn't do well on another modality. Home should be the starting point. So we need to make changes in how we view home modalities. We need to educate patients, nurses, and physicians, absolutely key. We need to continue to push for innovations in technology, new care models, and how do we build knowledge going forward for all these stakeholders. We need to take care to the patient rather than the patient having to come to us. And we really need to look at patient experience, cost, and patient outcomes as we redefine how we as a practice are going to be seen by networks that are designing the networks they want to have patients referred to. We want to be part of that. And unless we pay attention to cost, outcome, and experience, that won't happen. And the last point is that every practice should devise metrics which measure success for meeting the executive order, advancing American kidney health going forward. So I'll stop there. I'm more than happy to take any questions, CJ, but I'll turn the floor back to you.
Thank you, Dr. Schrieber. Anybody has any question, please put in the chart. Dr. Mark Rokowski from Southern California Kaiser mentioned he thinks residual kidney function should be one of the important measure of quality for PD patient.
Yes, I totally agree with Mark, and I believe that we ought to be monitoring how do we preserve residual renal function. We know that residual renal function has an impact on morbidity and mortality, and we know that preserving residual renal function significantly decreases patient mortality. So we need to be really focused in on residual renal function. And most people don't know that you begin to see changes in intravascular volume when your ultrafiltration rate is 5 to 6 mils per kilogram per hour.
Correct.
And if you go higher than that, you may begin to be seeing abnormalities in perfusion, which can adversely affect the brain, the heart, as well as the kidney. So great point.
Now, follow up on that, my personal view is we should move away from adequacy. I think Jeff Pearl mentioned this 2 days ago in a webinar. Instead of looking at optimization of dialysis, not just adequacy of dialysis. I think we should, in my view, it's time for us to move away from measure the BUN, the small molecule clearance, like KT/V, but look at the whole person, whole patient as a whole. Are they eating okay? Appetite is good. Are they sleeping okay? Are they enjoying life? Like right. Dr. Schiller's comment, go in satellite humanized dialysis. Yeah. We need to, like oncologists, have some kind of a Karnofsky score instead of just KT/V, to look at the whole person's how well they are doing. Since there's two things like the pandemic and the Advanced American Kidney Health, can we use this to go to the policymakers, say, it's time for us, quote, to retire, quote, KT/V in the United States, instead of looking at the whole well-being of the patient?
Yes. I think that's a great point, CJ. What I would say is that, as you know, it would take an act of Congress to change KT/V. And so while that may happen, as we think about what Congress is able to do in Washington, it may take some time. But I do believe that we need to do a better job in assessing patients up front. We need to assess them for residual renal function, and we need to assess them for learning styles, their functional capacity. Social workers and dietitians play a key role in this transition from CKD to ESRD, and no one should mistake their importance, because nutrition is critically important, and the social workers are absolutely critical in helping make that transition, and really identifying people that are depressed, because I think depression plays a big role in quality of life and how people are successful on dialysis. So it does take a team. We forget, when you have end-stage kidney disease, you are a complex patient, and it's very difficult to manage complex patients in small programs. We really need to think through, how do we make every small program in the United States a big program? And by virtual medicine and having a virtual platform in a practice, I think that can go a long way into really providing every single complex patient in the United States that has kidney failure the support that they need to be successful.
Great. Anybody has any other questions? Please put in the chat box. Yeah, there's a comment on depression is a huge issue right now during the COVID. We've seen a patient now testing and assessment.
Yeah, absolutely true. And don't connect with patients less because COVID's here. We need to connect with patients more. I mean, I'm seeing peritonitis rates go up in the United States, and I worry that COVID is having a distraction on patients, and they may not be receiving the training that they should. They may themselves, when they do the exchanges, may not be thinking about it as much as they should, because there's so many other things distracting them around them with COVID.
Right, and social isolation is also contribute to depression. The social worker at my clinic, her name is Natasha, has started a Zoom patient support group. I think it's a wonderful thing to do.
Wonderful.
Yeah.
Yeah, anything we can do to connect with patients more often, take them out of being alone. Being alone in COVID is really very difficult. And I continue to think we do need to connect, reach out to them. Every day we ought to be reaching out to some patients and just inquiring how they're doing.
So Anne Poon has a question. Consider making a wire telehub where patient can go to have their visits. If they don't have internet or phones, maybe in an MD office, library, lobby, or a clinic.
I think that's a great point. Not everybody has the ability to have internet or have a virtual visit. So we do need to have safe zones in communities where people can go if they need to really experience a virtual visit and not have to travel outside of their community. Great point. We have to do something about that.
Any other questions? Another question from Anne. Do they need to be full service connected, receiving dialysis paid for by the VA? Could they use Medicare, TRICARE, or something else in the community?
You know, I'm not sure I totally understand the question, CJ, but you know, there are aspects of support from all those different areas that do exist within a community. And I think that we more and more have to look at how do we accomplish something as opposed to thinking that we just can't get it done. So I would leverage all the resources and all the payer platforms that exist out there to accomplish the care we would want if we were a patient.
Great. We have 2 minutes left. If there's any more questions, if I can give another comment is, I hope in the future, all the healthcare insurer or healthcare system will provide patients with technology as part of the enroll process. For example, iPhone, so they can check the EKGs, monitoring blood pressure, monitoring their pulse, and also even set up broadband at their patient's home as part of the payment they pay for their insurance. So we can provide more remote care. Eventually, my dream is their technology is so great, we can hologram ourselves into patient's home, into the dialysis clinic. It's a true home care.
Yeah, I think that's a great point. And we don't talk about that as much as we should, but if you have chronic kidney disease, you should have access to remote or virtual visits earlier than when you just start dialysis. It ought to be upstream. And, you know, educators ought to be able to connect in with you. You ought to be able to connect in with your specialist or your primary care or a nurse practitioner that's monitoring your care or chronic care management. So I would agree 100%. That's a great point to make, CJ.
Great. Thank you so much.
Oh, it's my pleasure.
This is not the end. I think it's the beginning of the discussion. We're looking forward to your future talk. And by the way, I attend all your conferences, WebEx.
Great.
I learned a lot. If you don't mind, spend 1 minute to talk about all your WebEx available so everybody can join. Yes, and so, you know, we are having a number of WebExes that deal with home hemodialysis. We had several this week, and dependent on your time zone, it's sensitive to your time. So we really sequester small parts of the United States into different time zones, and I think it's quite good. So we have had webinars on patient selection and some nuances of training. I'm super interested in the use of both learning styles as well as the pocket echo to train patients to access their vascular access and to see where the needle goes in. We're going to be talking about prescribing for HHD. We will also have a series of talks on peritonitis that I think are critically important, and really how to design the workflow in your unit or your programs to achieve the best patient outcomes. So CJ, I appreciate the opportunity to just say a couple words, but we are committed to really building knowledge in the medical community going forward. Great. Thank you so much. All right, CJ, thank you. Yeah, and we'll be back on 10:05.